Conversations in Frailty, the podcast for Derbyshire clinicians.
So welcome to episode 10 of Conversations in Frailty. It's lovely to have all you regular listeners back, and I've had some really positive feedback which is great to hear. Do keep spreading the word, because I'm sure there are other clinicians out there, doctors, ACPs and so forth, who might benefit from hearing some of the tips on these podcasts. So this is the second part of two conversations I had with Dr. Ding, local rheumatologist. For those of you who didn't manage to catch the first one, this one does stand alone, but do feel free to go back to it. It's got some useful thoughts about how gout presents in the frail elderly population, how we might mistake it sometimes for cellulitis as well as septic arthritis, and quite a bit of thought around how we manage acute flares. But in this second episode, we move really into thinking about prophylaxis. So we talk about titrating allopurinol, which is usually our drug of choice, to the urate levels. I also ask her a little bit about how we manage troublesome tophi, and then focus a bit about those complicated cases where the patient has a comorbidity, and we think about chronic kidney disease and congestive cardiac failure, which we often see in these patients and can make our treatment decisions a little challenging. So enjoy, and I'll be back at the end with a few learning points to take home. So I'm back again today with Dr. Ding, thank you, and we just wanted to carry on our gout in the frail elderly conversation. So last time we were ending around a bit of chat about managing acute flares, so I just wanted to pick up on that and think about urate levels, because that's something that sometimes we get a bit confused about. If we've had a patient who has had what seems to be a gout attack, they maybe even had to go up to SDEC, and that seems to have been confirmed, what would your guidance be about checking urate levels again and targets?
Although urate level often goes down during acute joint inflammation, is a negative acute phase reactant. So, but still, I think we often find ourselves checking urate at the time of flare, because often there's diagnostic uncertainty. It may go down when they are flaring, but it might not. Then there will be helpful to confirm a diagnosis as one of the markers that will support the diagnosis. Often, there are many differential diagnoses that will be considered. But especially when the first reading is low, but the clinical presentation still highly suggestive of gout, we normally would write on the discharge summary message for GP for this patient's serum urate to be rechecked 2 weeks after the acute flare has settled. That will give a reliable reading, and going forward, urate lowering therapy will be benchmarked against that one to drop it from that level. We usually suggest starting, unless you have significant renal disease, the guidelines suggest you start 100 milligram of allopurinol with gout prophylaxis, either colchicine, NSAID if no renal impairment, but steroid if both. So contraindicated to use either colchicine or NSAID, maybe lower dose of 5 milligram. This prophylaxis should go on for 6 months. So
we're starting them alongside to try to stop the allopurinol setting off another flare.
Exactly. Yeah. So start with 100 milligram allopurinol with the prophylactic agent, and you would do monthly blood increment to titrate the gout level, urate level, against the guideline, which is, I think that's your next question. So the target urate is 360 micromole per litre, according to the latest 2022 NICE guideline. if the patient have tophi or chronic gouty arthritis or ongoing frequent flares, we will have a more stringent, tougher target of 300. So you would have monthly increment of 100 milligram going up to titrate the urate level against your target until you achieve it. Often patient probably rest around 300 or 400 milligram daily. And then you will continue your gout prophylaxis often for another 3 months to make it total roughly 6 months, I think. Yeah.
Okay, fine. Well, I think that's just going back. That's interesting because you were saying that the urate level is, I think did you say a negative
acute phase reactant?
So it's
yeah.
almost like we have to think of it as an opposite to something like a CRP or
That's
a ferritin
right.
that goes up.
That's
I will
right.
try and remember it that way.
Yeah.
So a urate we would expect might go down in acute
Yeah, it might be
inflammation.
misleadingly normal.
Yeah. That's a helpful way to look at it.
Yeah.
Great. And so you mentioned tophi. I think something I read said that after 20 years of gout, about 3/4 of the patients would have some tophi. Does that sound a reasonable figure in your experience?
I find older people develop tophi more often, and the location is either elbows or women tend to. I think the later trial shows women get more on the fingers. You can get it on the toes as well, but yeah, it is more common as you age. I don't quite know. Probably that reflects the load, doesn't it? The urate load in the body. But yeah, it definitely feel more common in older people.
And would you say they're easy to distinguish from other nobbles on the hand, shall we say? So I'm thinking of things like, the
yes, that's a good question.
Nodes or the rheumatoid nose. How would you feel more confident it was a gouty tophus?
Very good question, I say. Yes, I think in terms of on the hand, for example, you're right. So you get Haberden Bouchard node, that would be very, very hard. The gout one tend to be slightly softer, but I think personally I found the sort of the yellowness, the almost like chalky yellow color that break through from the skin. You can see a hint of it. You might turn the finger around and just say, do I see some? And then the Haberden often is one blob or like a camel's back, two blobs on either side of that DIP joint, and dorsal lateral. But whereas gouty tophi tend to be like lots of little blip that has a bit of a yellow chalky ting to it. I think that's helpful. I feel that it's slightly softer. I don't know. I don't think it's a crystal that's soft. It's actually often associated with a bit of a soft tissue swelling around it. It feels, Haberden is just bony hard. There's nothing around it, just bone. The other thing you can get confused with is probably rheumatoid nodule. Thankfully, rheumatoid and gout are negatively associated with each other. Very rarely we see them coexisting. But just for the sake of argument, as a rheumatoid nodule are a lot softer. Fibroma is it the other soft lumps is the softest. Rheumatoid is halfway, and then the harder one will be the gouty tophi, and the really really bony hard one will be the Haberdens.
Yes, that's helpful. Yeah. And I know sometimes if they've had a lot or they're getting quite large, there is a risk that they can get inflamed or start ulcerating or discharging. So can you give us any tips if we have that on how best to manage them?
Yeah, I think this can be quite a headache, and it can even happen when you feel that the patient gout side is actually sort of controlled, is not that frequent, but you're getting more problem with the breaking through of the skin that itself cause pain, not due to the gout flare, but the local infection, open wound, also over the pressure point, you can't put shoes on. So I think it divided into probably two areas will be helpful. Number one is control the symptom, depending on the location, whether skin's broken down. Sometimes require hospital admission because if infection is difficult to control, you need major surgical debridement. You need to be patient needs to be admitted. But if it hasn't gone to that stage that bad, locally you can get a district nurse involved, try to dress the wound and let it drain naturally under sterile environment, and watch out for infections because it's an open wound, and also think about their footwear, because the shoes obviously, or even slippers, might have to be cut a hole, otherwise it'll be rubbing on it. So those small things, and also pain control. As I say, the gout might not be flaring, but they have a broken area there. They walk around, everything rub on it, so it will be a lot of pain.
Painful
And
ulceration.
leading to difficulty walking, a fall become more often. So all that needs to be considered. And well, you don't want them to get admitted with a hip fracture just because they try to walk on that gout tophi. But if it's really the infection that that you got erythema infection spreading up, if they have systemic symptoms, you need to bring to hospital for IV antibiotics together, getting the surgical review, and then often they need a surgical drainage or excision will be required. So the other angle for this is, once you've dealt with the local problem for this area, that you need to think about be more aggressive with your urate lowering therapy to make sure you reduce the overall urate burden, so that you don't have another tophi coming out of the other foot, and then reduce the size as well. Then it's easy said than done, because often you can't really do what we do in rheumatoid treatment to target, because we discussed briefly, they have a lot of other comorbidity, polypharmacy, and that will restrict the dosage you use for the urate lowering therapy, and also used for acute flare. So so it's not as easy.
Do you actually see the tophi shrink sometimes? If you do, you can get them really shrinking down.
Well, the first thing is that they don't develop any new ones, and then the old ones, if it didn't need the surgeon to take it out, then it would. But it takes much, much longer, month of. So I think in comparison, treating a gout attack actually is simpler. Or you could you got the acute medication or steroid, whatever, it can actually shrink it down quite quickly, and patient can go back to their previous walking or function, whereas the gouty tophi take longer to go, and at times you might not even think is it going anywhere, but
And you mentioned there that comorbidities are often, in this group, that's what we often struggle with in terms of treatment. So I was just going to touch on a couple of them, the common ones we see, and unfortunately quite a lot of our patients have both of these simultaneously, but chronic kidney disease and congestive cardiac failure. So just any brief thoughts around, these patients who have got gout and they've got chronic kidney disease, what are the key sort of things we should be thinking about?
Yes. Well, chronic kidney disease not only make the management for both acute and longer-term prevention difficult for gout, but gout is actually more common in patients with chronic kidney disease, isn't it?
Right, yes.
That's why. So the two is so tangled. It's often very difficult to manage. But I think if I just divide into acute and longer-term prevention. Acutely, I think if you're talking about CKD 4-5 with the EGFR lower than 30, definitely avoid colchicine, because those patients they might be hover around 30, because the next day with a bit of diarrhea they could just go down quite quickly. They don't have any renal reserve, so it can be, and then colchicine, which is metabolized by the liver, excreted by kidney, so you could quite easily the level build up to a toxic level.
That's helpful, because the BNF is a little bit vague about that, isn't it? So actually thinking that diarrhea is really common and that will knock the kidneys off worse. So that's right.
So I think then you already know in kidney disease you can't use NSAID. So you really not much left. I think steroid is the key, but I would still look at how many joints affected. If it's at all possible, I would, if the joints affected amenable to intra-articular steroid injection, I will always try my best to inject locally rather than give them systemic steroid. Okay. But there will be time that you have to do that, multiple small joint involvement, or just so many hand and feet
patients who refuse to
Yes,
go to
that's
hospital.
right.
Yeah,
Yes, that's right. So I think then you will have to use oral steroid. So if you just have kidney disease, you can use steroid at the recommended level by night. With severe attack, you give 30 milligram daily prednisolone for 3 to 5 days. But if it is halfway, not too many joints, but not amenable to injection of steroid, you should consider lower dose, 15, 20 milligram. Yeah, daily.
Okay. And moving on to the sort of heart failure, I think a lot of us are aware that diuretics, which obviously, lots of our heart failure patients are on some furosemide, and we're aware that that is something that can make gout worse. Any thoughts around is there a better alternative to furosemide, and in terms of what we should be doing in the prophylaxis, I suppose, as well?
Yeah, I think it's really a difficult situation. When they come in with high dose furosemide and it can't really easily drop because you worry about they go into pulmonary edema or like swelling getting worse. Sometimes we consider switching to bumetanide, which is slightly better profile, but probably not enough. But if you're really desperate, you can convert 40 milligram to 1 milligram conversion bumetanide. But I think I think the use of that is quite limited, and we often have to give steroid to settle the flare. Just by switching diuretic is not enough. I think in this patient, you need to think about other medications because these patients often have they might be on needing some blood pressure medication. Would you actually want to give them amlodipine, which is helpful in management of gout, reducing urate? Data have shown that. And if they use if they are statins borderline, well, they probably most of them on statin, but atorvastatin got really good data to lower urate, so you might want to preferentially give them that one. And then if you have to give them a ARB, losartan, there's a drug-specific effect, a uricosuric effect of losartan. So I think that should be preferentially used. So a little bit switching around. And if they have a lipid problem, fenofibrate, surprisingly, had good trial evidence in that reducing incidence of gout should be considered. I think in this patient, I don't think doing one thing often enough. You really should just look around, whatever you can optimize. And some of them, like the losartan, it could be one stone, two birds. You should definitely consider the low-hanging fruit here. But probably do not stop aspirin. It can increase the urate level, but the cardioprotective effect is so great that you would just take that risk, and then maybe to up your urate lowering agent to compensate for that rather than stopping aspirin.
But that's really interesting, because I have to admit, those are all new to me. So I think you mentioned amlodipine, atorvastatin, fenofibrate, and losartan as all drugs which should potentially lower urate. And I wasn't aware of that, so I'm guessing some of the listeners probably not as well. So that's really helpful.
Very useful.
Great. And for buxostat, which we sometimes use instead of allopurinol, is something we should be avoiding.
Yeah, we should try to avoid in congestive heart failure. I think I found myself still using allopurinol more, although both allopurinol and fenbuxostat are listed as first line for prevention in the NICE guideline. But I think you too. It's just allopurinol being around for longer, isn't it? When we have a clear titration. That's right. Yeah.
Great. And I feel like I can't seem to finish one of these podcasts without talking about deprescribing. It's just our watchword in frailty at the moment, and probably will stay that way. So just thinking about, a lot of our patients are getting to the point where they are perhaps, housebound, moving into care. When should we, particularly, the patients who are on long-term prophylaxis with something like allopurinol, when would be a reasonable point to start thinking about, actually, is this appropriate still? And if we do stop it, any tips around best ways to do so?
I think deprescribing is, like you say, my understanding, if it's no longer a clear benefit from this medication, we should consider that. For gout, if the patient have not had a flare for several years and no troublesome tophi, or preferably no tophi, and the urate level has been consistently in the normal range, I think it definitely should be considered for a candidate for the prescribing allopurinol. And I think if you do that, you should do it with the patient's engagement, or explain if it's a nursing home patient with dementia, maybe talk to the family as well, or the nursing home staff, because if it trigger flare, what should they look out for, and if it happens, who should they contact, and what would they, we need to reassure the relatives. We will give them, they won't be in pain. We will give them, whatever is appropriate, often probably it's steroid or injection to settle the pain, and maybe have to put them back on allopurinol again. So that's so patient need to preferably be involved in the decision making, and also you should do it slowly rather than just take it off. You may even want to monitor the urate level, see whether it's going back up. It might not do, but certainly, at the very least, to actually monitor whether they actually start to get attack again and the tophi start coming back again. So you know where you are then. Yeah. For the patient with on the end of life or really limited life expectancy, 6 months or less, I think you probably, the decision making will be much easier, I feel, because after all, allopurinol or femboxostat is trying to preventative medicine, prevent attack in the patient with a very limited life expectancy. I think it is the symptom management that take priority, isn't it? So I think you'll find it easier to wean them off or take it down. Yeah.
Fine. Excellent. Well, we've covered lots of useful stuff again, new to me and hopefully new to the listeners. So thank you ever so much for your time once again, Dr. Ding. And
thank you.
We really appreciate that.
Thank you very much.
Thank you.
Well, I think it's a challenge for me to pick out my favourite learning points today, but hopefully that means there are plenty of them for all of you listeners out there. 3 things maybe. One was just a useful reminder of actually, if we're starting someone on allopurinol, roughly how long should we be covering that with something like colchicine? So her guidance of up to around 6 months was a helpful pointer. One point for those CKD patients, which I liked, was the BNF says use colchicine with caution if the eGFR is between 10 and 50. Her thoughts were actually, if it's less than 30, think twice, because as we know, colchicine can quite easily cause diarrhea, and if you've got a patient with poor renal reserve, that colchicine course can knock their eGFR down quite quickly. So I thought that was a really helpful flag for us. And finally, a learning point for the congestive cardiac failure patients with gout. As Dr. Ding put it so nicely, pick off the low-hanging fruit. Sometimes small changes to medication can help to reduce the risk of flares, and the atorvastatin, amlodipine and losartan seem to be specific drugs in their classes which have urate lowering potential. So if you can do switches to those, that might be something worthwhile and hopefully quite straightforward to do. So I am already looking forward to recording episode 11, and I hope you will join me for that. As I say, for all of these episodes, I was interviewing as an individual expert in the field. So when you're making decisions around individual patients, do take local and national guidelines and your clinical judgment into account. And just a reminder again that the shared care pathology guidelines for Derby have some really helpful basic guidance around gout management. Thanks for joining me.
Conversations in Frailty. Thanks for listening.